Okay, so good morning, everybody. Nice to see everybody up so bright and early. And yes, I'm going to be presenting a case that really highlights the importance of collaboration when you are managing patients with severe tricuspid regurgitation. So this case is not actually an unusual one in terms of her background history. 87-year-old with HFpEF, chronic AF, progressive RV dysfunction in TR, both now severe, and with recurrent admissions at an outside hospital for essentially acute on chronic right heart failure. Pay attention, this is her list of medications, because I've got a question that's going to come back to this, but there they are. These are her physical findings. Blood pressure is adequate. Her heart rate is 82. She is fibrillating, but she has clear-cut markers of clinical markers of severe tricuspid regurgitation, and she also has RALs at both bases and anasarca reflecting her chronic right heart failure. Her renal function is not too bad with B1 and creatinine as noted. Note that her pro-BNP is over 13,000. Her EKG shows AFib with an incomplete right bundle branch block. So here is her basic transthoracic study. You can see hopefully very quickly that this person has secondary tricuspid regurgitation with significant, as in massive to torrential tricuspid regurgitation. In terms of the secondary part of her diagnosis, we felt that this was due to a combination to her chronic HFpEF as well as for perhaps a component of atrial secondary tricuspid regurgitation with those leaflets just pulled apart and massive left atrial massive right atrial enlargement. Other findings on her baseline transthoracic echo, her LV size and systolic function were normal, pretty much as expected. Her RV was severely dilated, moderately hypokinetic, difficult to estimate PA systolic pressure in the presence of such severe tricuspid regurgitation. So I would say it was at least 34 plus whatever her right atrial pressure was. And her tricuspid annulus, measured in a 4-chamber view, was 4.9, so clearly enlarged. So the question to all of you, to us at the time, is what would you do with this patient? So here are your options: TEER, tricuspid valve replacement, the transcatheter approach. Do you do surgical tricuspid valve procedure? Hospice, is there really nothing you can do, or medical management? And I only have 5 minutes, so I'm going to go ahead and give you the answer. The answer is medical management. And the reason that I pointed out this list of medication is this is a pretty paltry list of medications for someone with that much tricuspid regurgitation, that much underlying heart failure. So she was referred to our heart failure team for medical management. Unfortunately, in her case, it did not eliminate the TR, although sometimes it does. I'm just going to point out that even if you don't eliminate the tricuspid regurgitation, getting people decongested has important implications in terms of survival following subsequent intervention. So medical management, both pre and post. So what to do next? Well, we decided that we would go ahead and do tricuspid edge-to-edge repair. And this is a procedure, again, that visible coaptation gap in the TR. And this is from a transgastric view. You can actually visibly see a sizable regurgitant orifice, which you see better in the sort of still frame here, kind of a sort of tricuspid-looking or triangular-looking orifice. First clip goes in, and there's still a lot of tricuspid regurgitation. So a second clip, which had been the plan, was attempted. And unfortunately, during this, in trying to reposition the clip to get a better result, the cords were torn, and you can see in the upper left right here, there's a significant flail segment. You can see here the one clip that's in place. So her TR certainly at this point was no better, in fact, arguably a little bit worse. So what to do next? At this point, we decided to go ahead with planning a tricuspid transcatheter valve replacement. I would say that she was not considered to be a surgical option, but we weren't ready to give up. So the valve that's commercially available is the Evoke valve. In sending all our information off to Edwards, which is the maker of this valve, they come back with a very detailed plan, including the recommendation that it was an anatomically suitable valve for a 52 millimeter Evoque valve. Problem, though, was that there was a clip dead center, and if you're going to put a valve inside, you have to have a big enough orifice on one side or the other. And here's our clip that's in place, and neither of those side orifices was going to be big enough to accommodate Evoque. So what to do next? Well, what to do next was to get that clip out. And there is a procedure called ElastiClip, mostly has been developed for the mitral side, where there's electrosurgical laceration and stabilization of the valve. So this is kind of a schematic that shows what the goal is. The goal is to sort of lacerate the tissue. This is obviously a mitral valve schematic, but you kind of tear this, and it leaves the clip attached to only one of the leaflets, and therefore gives you back a single orifice. That was the goal, and this is kind of what the procedure looks like. It's an electrified lead that goes across, and you pull, zap, and there you go. So this is this happening here, elastic clip. There's our clip. And not unpredictably, because we were prepared for this, because the clip was so fresh, it fully detached from the leaflets to which it was attached, wound up in the right atrium where it was captured and ultimately anchored down in the IVC, where it was ultimately removed surgically. Here is the Evoque valve going in. Multiplanar reconstruction is key in this procedure, and this is what it looked like at the end. You can see it here in multiple views, and this is the en face view here. Gradients were really pretty good, a mean of 3. And this is, again, a view of what it was doing functionally with really a small central jet and an even tinier paravalvular leak. These valves, when they go in, if they're appropriately sized, they really do not leak, which is a wonderful thing to see. So at this point, not quite done, because she had high-degree AV block. Her heart rate had dropped to 35. So we know that this happens not infrequently in patients who've had tricuspid transcatheter valve replacement, 15% at 1 month in this series, and 12.4% requiring permanent pacemaker, which she did, and typically this declares itself relatively early. So the last part in terms of procedures for this woman was to put in a leadless pacemaker, so you see it in place there. At 1 year, she was a patient who was on very shortly after commercial approval for Evoque was offered. She was feeling well in New York Heart Association Class 2, and I can tell you her numbers all looked much, much better. This is what the valve looked like transthoracically, just so you know. And just a teeny, if you look very closely, a teeny, tiny bit of central tricuspid regurgitation. So by way of summary, I think this case illustrates very nicely the continuing expansion in terms of options for tricuspid regurgitation by a catheter. TEER and Evoque are commercially available now in this country, but still optimized medical management pre- and post-procedure is essential. The device therapy, as I've shown you here, may involve multiple devices, and the valve team is essential. So who's on the valve team? These are just the key people around the table in this case. The interventionalist, of course, the imager, the heart failure person, surgeon who offered the opinion that this was not a surgical patient, but in some patients that might have been an option, especially after failed clip, and the electrophysiologist. Don't forget our industry sponsors, because especially for valves like Evoque, they're very helpful in terms of pre-procedural management. So thank you for your attention, and I also want to shout out to my team back home who did this case, Dr. Gennaro Justina, Dr. Rob Kipperman, and our imager who took all these images, Dr. Costa Kouligianis. So thank you, everybody, for your attention.